I'll say when we get to our welcome and introductions, I'll say a little bit more as well about particularly the infection prevention and control. Okay. So if I can welcome everybody to this meeting of Nottinghamshire Healthcare NHS Foundation Trust's Board of Directors. You're very, very welcome. And indeed, we are meeting in person for the first time since January 2020, and we do have some colleagues, some staff and governors who are observing in person here. Just before we get going, I would just like to say that we've taken a great deal of care in setting up this meeting. We are following some robust infection prevention and control guidelines for how we meet. So it's the first time we've done this in person for well over a year and a half, and we will be reflecting on our learning from this as an event again. But you're very welcome being with us, as are our colleagues who are observing. And as always with our board director meetings, we start the meeting with hearing from a patient or staff member. And it's a really important piece for us because it helps us just make sure that we remind ourselves of why we are here as a board. And I'm really pleased to say that today we've been joined, and again joined in person, by Colin Stubbings, who's going to talk about some of his experience having used some of our services. And he is supported by Eunice Hussain, who's the Trust's employment specialist. So what I'd like to do, if I can, is invite Colin just to tell us a little bit about your experience, please, Colin.
I am Colin from, well, I was brought up in South Africa. Born in England, went over very young and that. We did have quite a few hard times in it. Brothers. One was murdered, and the other one died because medical wasn't good and things like that. I ended up putting myself into the army. I'd done my army service in South Africa. When I came out, I went into the services for the government on policing and things like that. I've seen quite a bit in life, done quite a bit there. Yeah, a lot of people have problems and things, but those days I was seeing it in a different light compared to now, if I can put it that way. My then father-in-law, he was a lieutenant colonel, and so maybe that helped me a bit, I don't know. But I was then doing some undercover work and things like that. Done that for about 4.5 years in total. I then got out of it, and then I went into the security side of everything. Ended up working for, at that time, the biggest retail supermarket in South Africa as security management, where I was taken hostage twice, where I was shot at a few times. One day I had a whole AK-47 magazine emptied on me. I found that actually harder than the police job in the army. I then decided to change my career and go into something different. I ended up going into sales, tried sales and that, but I always got pulled back to the security side of things, and ended up as an area manager for a security company. At that time, I had my own house. I actually was starting my second one. I had my own car, my wife had a car, private pension, medical aid, everything. And one day I was at the table, just like this, writing, and then I woke up at the table. That's all I remember, and I was in a pool of sweat. And I walked to the person in charge and explained, I don't feel well. And then I just grabbed the door and I went into excruciating pain. And I fell to the floor. I started crying like a baby. I was screaming, I was shouting, I was swearing, it wasn't me. And, but it was extreme pain that was in my head. And that carried on for a while. So, the one day I was sitting in the office, people that I helped, people that I protected, things like that, I actually heard them saying, "Oh, the guy's crazy, he's losing it, he's not right." And, you could hear them talking. And I thought, no, I'm removing myself from the situation. And so I went home, and I ended up getting locked up twice into a mental health institute in South Africa. I mean, half the people that I were locked up with were people that I arrested. So my life was in danger and things like that. So it was a difficult situation. And the one day, I don't know if it was the head or the nurse or someone walked in and says, "No, you shouldn't be here, you've got a problem." And then they realized I'm suffering with cluster headache. And but I was getting up to six attacks in the day, and then I was still getting in the night as well. Each of my attacks was 1 hour and 5 minutes. So from there, I became secluded from everybody and everything. I just kept myself away because I didn't want to hurt people. Because my own mother touched me and I threw her over me because I thought I'm under attack. And, that's how I became. So I didn't want to hurt people. So I went away. My wife ended up looking after me for 20 years. She done everything for me. My son was raised with me with this problem. He helped me all these years. I sat in a chair, curled up in a little ball, 22 hours of the day. The time I got up when I went to go shower or to go to the bathroom, I didn't go out by myself. I still don't go out by myself at times. I'm still scared to go out. But that's, as it's going through. But I don't know, one day we decided, no, we're going to come back to England because logically I lost everything as well. And my dad said, well, at least England, we got the NHS and things like that. So we scraped up everything we could, and I came over first. I was here 6 months. My wife came after. And I must say, the first day that I walked into the NHS, it was just down the road in Sherwood. The doctor started taking me off all these medications I was on and all of this, and started bringing it down. But then I ended up going to London, under neurology in London, and that's where my life started to change, because I started to get the right help, the right understanding and things like that. But yes, I was always on medication. And then one day they put me on medication and I ended up getting migraine from it. And still today I've got migraine from that. It does not leave me. I'm permanently got a haze in front of me, and I'm permanently on different levels. So that's all difficult. But now, because of the time I was sitting at home on a chair, I was going through every single arrest that I've been through. I was going through every time that I was taken hostage. My brothers had died, blaming this, blaming that, thinking God's punishing me. It was hell on wheels. I was like in my own little prison in the house. I had 4 walls. That's it. And I got to start to see psychiatrists and psychologists, and even in South Africa, I went to one of the witch doctors to try and get help. And that's how I felt. But one day, I went through the systems, and I ended up moving to Sutton in Ashfield. And it took a while before I got to Millbrook to go see a psychiatrist. And unfortunately, that day I went and I sat there, I was actually in pain. And the psychiatrist came out and I really wasn't feeling it. And I apologize for today of my attitude and things like that. But it actually worked, and it worked in my favor that day, because I walked out and then I was asked to come see somebody else. And the day I walked in, Helen was standing there. She walked up to me, she put her arm around me and she said, "Come with me." She literally took me like that and said, "Come with me." And we went into the office and she started to talk to me, but the way she talked to me was, "Okay, come." let's talk. And she was straightforward, bang, 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 that's it. And then she introduced me to Lisa. So then there was the two of them working with me. And I don't know, I just opened up, I think. But because I felt secure, I felt nice, and they understood what was going on. Then I got to meet Mike. He's my psychologist, I presume. And the way he started to explain things to me. And during that time, I ended up having an operation. I keep forgetting its name, where they put spaces in to move the nerves away and things like that. So that helped, has made my pain less. But then he started to explain to me, okay, Colin, if you've got a cluster attack, you might feel useless at that time. You might be screaming, you might be crying, you might be blaming the world, you might be doing whatever. But when that pain is gone, are you still Colin with all that experience, or are you useless? And then I started to understand, and I started to realize, well, it's fact. And I don't know, I just started to progress. And the one day I was sitting there and I said to Mike, well, you even came to my house, or wherever I wanted to go, or wanted to go for a walk, or whatever. That's how, I don't know, how easy they were with me. And whatever I wanted. And the one day I said to him, I need to start doing stuff. I need to get out there. I'm scared, yeah, logically. And that's where I was introduced to Eunice and Sangeeta. And I think the first visit, if I remember correctly, they came to my house as well. I was sitting in my chair. And they started to go over a few things with me. And I don't know, again, I just felt at ease. It's the way that they presented themselves. They came in, it was nothing forceful. It just went with the flow. It went nice. And they understood what I was talking about. And on top of that, if they didn't, they went and actually found out more about it. And then, because the second time they knew about my situation, they knew what it was, what it does to you, and things like that. They then got me a little job in a charity shop, Hetties. And I was scared. I actually even walked down. That was the first time I walked down the road in 20 years. And I went there, walked in, introduced myself. It was like if a bomb hit the place. I just got stuck in, was cleaning it up and everything. And then unfortunately it closed. I don't know why they closed or anything. They didn't really come to us about that. And then I felt, I suppose that's my life. It's going to go nowhere. And then this was there again. Let's start looking at something different. And then a job came up at Millbrook. And I went, we applied for it and everything. And Eunice was talking to me, explaining to me, helping with my interview, everything like that. So getting everything sorted for me. Went into Millbrook and I met my then boss at that time, Mark and Sharon. And it was for domestic. So I went in as a cleaner. So I was saying to myself, I'm going from this to this, but it was a stepping stone. And I did tell them that. I did say, yes, I'm coming in, but I am, and I do want to go forward. Because my first question to them, would I have a chance of becoming a manager one day? So he says, yeah, the chance would be there. So I thought, okay. And I ended up getting the job, but on bank. And I think it was a few weeks later, COVID hit us. And the first day I worked an hour. I came home, I was so tired, I just wanted to sleep. And then I started progressing slowly. And then COVID hit and I was on the COVID wards. And I worked on the elderly wards. And then I started to realize, talking to them, even if it's 5 minutes, just 5 minutes, that they are actually registering something, saying something to you, just that 5 minutes, you can feel it. You can feel it. And then I realized, and I went to Eunice, I said to Eunice, I need to start helping people. I need to be on a ward or be on the street, helping people that's got drug problems, alcohol problems, whatever. I think that's how I first put it to him, and saying that I need to get out there, I need to get people. And he started to help me again. And we went through so much. We went through so much talking, so much preparing and things like that. And at that time, the vaccination roles came out, helping at mass vaccination. So I applied for that. And I got in. And yeah, okay, I was taking people's names and things like that. But you had people coming in there scared. They were scared to get the injections. And then I found, wow, this is nice talking to them. I'm scared, but talking to them and getting them a little bit happy. And then a lot of them came out and they actually thanked us. Not just me, everyone else that's there. And I felt great, I felt powerful, let's put it that way. And I said to Eunice, no, I need to go forward. And so we started applying for peer support positions and things like that, and I fell at every hurdle. I just, somehow I wasn't getting something right. And then the HCA job came up at Highbury, and I got into that. And permanent as well, which is even better. It's a lot nicer. It's a challenge on Rowan 1. It's heartbreaking, to see what people are actually going through. If you just sit and listen to them. I mean, I believe no one wants to be like that. If something is out of the ordinary, something's wrong. And that's where we need to work on. That's what we've got to sort out. Listen to them, talk to them, and try and explain things, experience, things like that, get things across to them. So yes, I love that job. I really like it. But I've got a lot to learn. And I need to learn as well. I need to become better. I need to get out there. The only thing I don't like about it, to be fair, is I don't like being hands-on. Mm-hmm. That's not what I'm there for. But unfortunately, sometimes we have to. I prefer to get the talking going, and it usually works. It usually works. It just doesn't, and that I find hard. I prefer, like I said, just to talk to someone.
Colin, I'm going to pause you at that point, if that's okay. Yeah. And before I open it up to colleagues, thank you so much for coming along and sharing that incredible story, sharing some of those real challenges in your life, but also what great achievement you've had. And I'm really, really pleased that you're a healthcare assistant with us. And I also know that you're still very interested in peer support as something where you could obviously bring more in. And just to say thank you to you for particularly the work that you did on the COVID wards, because that's particularly challenging. And given the experiences that you'd had previously, for you to have been going in there each day, I'm sure was a really, really big commitment. Can I open it up and just get a couple of comments from colleagues, please, if I get anybody who wants to give a comment or a question? Trevor.
Is that working?
Yep.
Colin, you talk about courage and, well, particularly about bravery and being scared. To sit there and tell that story takes huge courage and demonstrates real bravery to do that. So take that. That's a really, really powerful message for us to take, that somebody that's come from the situation you've been in, and to sit there and calmly and collectively tell such a powerful story is really impressive. So well done to you.
Thanks for that, Trevor. Anybody else? Carolyn. They're all on.
Colin, thank you. It's not a question, it's just it's a comment, really. I think we're sitting here, there's big screens behind us, and our trust values of trust, honesty, respect, compassion and teamwork absolutely came through in your story. So I just wanted to say thank you for sharing that and being so candid with us. It's really powerful, made me feel quite emotional. Thank you.
Thanks very much. And John, I wonder if you just want to give a final reflection before I wrap up.
Myself from my mic. Thank you, Colin. I'm John Brewin, Chief Executive. I think we're all quite overawed by your story, and particularly with 20 years plus of having to cope and being isolated to get then from there to where you are now is a phenomenal achievement. I just so one question in terms of whether you needed much persuading in terms of all the different sort of interventions and treatments and therapies that you'd had, whether when you first met someone from the employment team, whether you needed much persuading that was a good idea or not, or had you given up all sort of hope, and what did you see your future as?
I wanted to die.
Mm.
That's it. And it's like I say, if it wasn't what happened that one day and when I met Helen and them, and especially Eunice, nah, I mean, he knows as well, Mike knows as well, that there's many a times I don't want to be, I felt totally useless.
Yeah.
Really, I did. What they have done for me, I mean, they always say, oh, but it's also me. But, you know, if they didn't give me that push, I wouldn't have done it.
Yeah.
If they didn't say that right word, I wouldn't have done it. I don't think I would have. I don't think I would have been here by now.
Yeah.
I did try to kill myself a few times. I thought about killing myself every single day. At that time, it felt right.
Yeah.
So I understand when someone talks about it, you know, to be in pain 24/7. My wife had a headache the other day and she was, I had to shut up. But yeah, so it just shows. And then the way that they explained it to me and told me, even Eunice has said to me that, you know, he's had a headache and his attitude changes. You know, and I start thinking.
Yeah, thanks. No, so and it emphasises Karen's point about teamwork, isn't it? It's a two-way thing. But I think it's a brilliant example of the broader individual placement support services, the tremendous impact they can have on people's lives, and where you've come from and where you've got to. And as Paul said, I'm really pleased that you're able to be contributing and working for our organisation. I'm sure people on the receiving end of you, when you're working on the wards, get the benefits of your experience and your compassion, and that's fantastic for them and fantastic for us. But to thank Eunice and the team as well for all that you're doing, because this is a relatively underfunded, hidden aspect of mental health provision, not just in the county but nationally too. There's been a big focus on it in the last few weeks, but this is a brilliant example of what's possible when people work together and make this sort of progress. So thanks very much, both of you, and for your team as well for all that you're doing. It's a great start to the board, Paul. Thank you.
Thanks. Just did you just want to make a comment as well before we move on?
Comment on what Colin had mentioned, and also the answer to your question as well, John. Typically, the service users that we support have got a wealth of background, working background, and the biggest motivation for certainly Colin was when he was, let's say, when he said he was at the top of his game. He had an extremely strong work history. Work was a big part of his life, and for him to get back to that strong Colin, so to speak, it was getting him into employment that would best suit him. And just to quickly touch on what Colin had mentioned is the support we provide isn't just into entry-level roles. We have teachers we support, solicitors that we support, we have bus drivers, delivery drivers, especially over COVID, where we found the biggest motivation for them is getting back to a sense of normality. And for us, the biggest motivation is actually the service users themselves. So anything that we've supported you with, Colin, it's literally just a support. You've done all the hard work. So thank you for choosing us, really.
Yeah.
That's great. Well, thanks so much, both of you, for taking the time to come along. Colin, really, really powerful, and we will keep you in our minds throughout the meeting today. And Eunice, thank you for your contribution in terms of supporting Colin and for the work that you and your colleagues are doing with so many other people. This is a real demonstration of the impact of that, and I'm sure that you take that into your heart as well. So thanks very much for getting us off to a good start today. So, round of applause as well. Sorry, Anne-Maria.
Yeah, can everybody just put the hand up who's planning to have their flu jab so that they know how many to bring over?
So just an indication who needs a flu jab today.
Okay, thank you so much.
Okay, we are taking advantage of being in a meeting physically to also do things like the flu jabs. I also know that all of those who didn't put their hand up will have had one already. It's not people not having flu jabs. So, welcome to the formal part of this Board of Directors meeting. My name is Paul Devlin. I'm the Trust Chair, and I've got with me the whole of the board plus some colleagues who are supporting us. Colleagues, as we go through the meeting, just a reminder that all the microphones are live, so you don't need to switch them on. And also, if you could just introduce yourselves, because we are socially distanced, our nameplates won't be visible for everybody. So if we could then go to any apologies for absence. So we have Becky Cassidy provides support to the board, who has got another commitment just now, but we're a full house in terms of the board. In terms of our part one, are there any declarations of interest that we need to note for this agenda? Manjit.
Just my usual declaration, please, Paul. I am currently working for Northampton Healthcare Foundation Trust, supporting some of the work on the Provider Collaborative.
Great, thanks very much, Manjit. And to say that today we haven't received any questions from the public. So if we go straight to item 6, which is the minutes of our last meeting, and could I ask if people could indicate by hand if you are content that the record of that meeting, please. I think it's a few people remembering that we've got physical hands to raise this time, which is great. So thank you. And in terms of the action log and any matters arising, the action log is there, and both items on there have got clear timelines for progress. Is there anything else anybody wanted to pick up in terms of matters arising that's not on our agenda today? In which case, if we could move to item 8, which is the dates for our 2022 board and committee meetings. And Shirley, if I could invite you to introduce this item, please.
Thank you, Paul. It's Shirley Higginbotham, Director of Corporate Affairs. So this is just the schedule for the meetings next year. It's all the board and council of governors and the committees. So it's just here for awareness and approval, please.
Thank you. I know colleagues have had sight of this, so I'm sure if there's been any feedback, that will have been taken account of. So again, could I just get an indication by hand if you're content to approve this schedule, please? Thank you very much. In which case, if we could move to item 9, which is my update. Just 2 or 3 things I'd like to highlight from the paper, which I'll take as read. First of all, a really big continued thank you to our staff and volunteers for your hard work focusing on providing support for those who need our services. I'm incredibly aware of the cumulative pressures that have come from the last 20 months. And I know that it is very, very intense out there, and we'll hear more about that at different points during our meeting. But a big, big thank you to you for keeping your focus on doing the very best that we can for those who need our services. You'll see from the report that I've actually been able to start getting back into doing some face-to-face visits of services. I'd say that there's always a caveat on that, which is, of course, if the pressures or indeed COVID are such that they impact, of course they get cancelled. And indeed, that there have been occasions recently where I've had visits cancelled, which is quite right. But it's a really, really good way of reconnecting with services. And I know my non-executive colleagues as well are starting to get back into those, as are the executive team. I did just want to highlight that John and myself have had a couple of sessions with our Freedom to Speak Up guardian, Simbi Sibanda. And part of that was an acknowledgement of last month being Freedom to Speak Up month, as well as us doing our ongoing work. Really, really important that staff are able to speak up, and that's a very important route for us. And I also just wanted to reference both Black History Month last month. I'm very much looking forward to seeing the video of our key celebration, which unfortunately I had to miss. And also just to acknowledge the National Allied Health Professionals Day, which was a great day, both being able to see some of our teams in their practice. I'm grateful for the patients and carers who enabled that for me, but also to have some really great conversations with colleagues. And you'll see from the paper that there's ongoing work at a system level as well. So I'll just pause at that point just to see if there are any comments in relation to what I've said there. In which case, let's move on to item 10, the Chief Executive's report. And John, if I can hand over to you, please.
Thanks, Paul. John Bruin, Chief Executive. Morning, everybody. Take the report as read. Not too many things to spend a lot of time on this week. The usual monthly updates on where we are with the CQC on page 20 in the pack. We're still continuing to focus on continuous improvements, improving quality, patient experience and outcomes. We're having regular engagement sessions with the CQC. Unfortunately, we still are awaiting not that we get a notice date, but we're still waiting for them to come and do a comprehensive inspection. But no sign so far. On 20 and page 21, again, there's a brief summary of NHS England and improvement priorities. And just to reiterate Paul's introductory comments, really, that all sectors of the health and care system remain massively challenged, whether it's primary care, whether it's the ambulance sector, acutes, community mental health, learning disability trust, but also social care provision as well. And our trust is massively challenged at the moment as well across many different directorates, predominantly around staffing. Staff are working extremely hard, but it's a daily and certainly a weekly challenge to make sure we've got compliant shifts and we've got cover that's providing safe services. And many of us are working to help maintain that. I just really wanted to emphasise that challenge, but also this is equivalent to sort of midwinter, but clearly we're nowhere near that yet. So there are concerns that the coming months will remain difficult. Within the rest of the report, there's probably not an awful lot I want to really focus on. So I'm going to take that as read, but just to emphasise something Paul mentioned about the visit. So it's been brilliant to be able to get out and see services. So we had a good day and a bit, half a day and a bit at Rampton. We've been to mental health services for older people at Highbury Hospital, and we had a fascinating and really inspirational half a day with the IDD team, so the Learning Disability team, both in Mansfield and at Highbury Hospital. And we've met both inpatient day and community services, and one of the conversations I had with Paul about how uplifting it is to get back to the sort of cold face, as it were, really, and away from being stuck on MS Teams and dealing with all the challenges, but to see so many staff that are really passionate and proud of the work they do and the good work they're doing for all our patient service users, really helps sort of rebalance your own sort of internal narrative of the challenges. So, and again, as Paul said, we're hoping to continue to be able to do that whilst conditions allow. And then finally, just to note the continued priorities around vaccinations. We're in the middle of the current wave of the vaccination programme. So we are, our trust is leading the vaccination for the 12 to 15-year-olds across the county. And we're having better uptake than we thought, so that's good news. And whilst that continues, the booster programme is also now in full flow, and our staff are starting to access that when the 6 months date is up from their second jab. And seamlessly, we now run into the flu programme as well. Massive national import rightly put onto this. You'll remember from last year that flu was almost non-existent for all sorts of reasons, not least that we all started to wash and keep away from each other. But the forecast for this year is that our relative immunity might be lowered, but if there's more of it around, the last thing we need is a convergence of flu and another. That's flu and COVID together, isn't it? Fluid. Them both together could have a really massive impact. So there's a real sharp focus on making sure that our staff kind of a flu jab too. And the final point from me, Paul, will be just to emphasise that we are in the middle of the National Staff Survey campaign. So really important that we encourage as many of our staff as possible to tell us what they think. We did tremendously well last year, and it'd be really good to embed that and go that little bit further this year. So that's a big part of our task at the moment. Thank you.
Right. Thanks very much, John. And just before I open it up to any comments or questions, just to also recognise that you've captured just some of the awards that our teams and individual staff have been both nominated for and indeed won, which are a real accolade, and it's great for those individuals and teams. It's also really good for us. So just to acknowledge those. Just open it up to see if there are any comments or questions from colleagues. I've got Manjit first, please. If you could introduce yourself, Manjit.
Yeah, thank you. Manjit Darby, I'm non-exec director. Just a couple of questions, please, John. First was about the impact of the mandatory vaccinations of care home staff and whether that has had any impact on us as an organisation, because we talked about it at the last board meeting, I think. And the second was really just headlines on kind of how the strategy work is going and how it's gone down in terms of those sessions that we've had, and any feedback that you've had from staff.
Thanks, Manjit. I'll perhaps ask my exec colleagues to answer those. They're probably closer to it. The sort of headline summary on the care home mandatory vaccination issue, I think, has been is that we've managed that very well. It's not had a huge impact. But where's Becky?
Good morning. Becky Sutton, Director for Community Health Services. So yes, I think we're still just in the process. We've written out to all our staff who we just check in vaccination status. So far, I don't think we've had anyone that it's been affected with at this stage, certainly within community services.
I suppose, Manjit, the next potential question is, okay, so what's going to be the impact on other areas if it's mandated across health? And people be aware this is a national conversation going on at the moment, and lots of calls for the government to hold off on making it mandatory because of the potential impact. And we're obviously watching that closely and see how the conversation pans out. But there are potential, significant impacts on staff saying, well, if you're going to force me to have it, I'll go somewhere else. And then the strategy question, I wonder whether Sarah, you might want to.
Morning, everybody. I'm Sarah Foley, Director of Partnerships, and have got responsibility for developing the trust strategy. Manjit, we've now done 4 workshops, particularly focused on the 4 strategic objectives, and we've also done divisional directorate and some service workshops as well. Met with the Council of Governors, so done a whole range of engagement exercises. I feel they've been well received. I think there's a couple of themes that are coming out, and it'll perhaps be no surprise that some of the language hasn't been perhaps as straightforward or plain English as it could have been. So what we've done about that is we've actually been working with the patient involvement group, and they've actually just redrafted our strategic objectives and our specific outcomes into more user-friendly language, and we'll certainly be discussing that as an executive team this week and next week, and then reporting that back to staff through connecting knots over the next sort of 4 or 5 weeks. So we really close that feedback loop to demonstrate that we are listening to staff.
Thanks for that update, Sarah. Manjit, just to see, are you content with those responses?
Yeah, no, very happy with that. I just wondered, Sarah, just in terms of the partner response to our strategy development, has there been any kind of views expressed by our partners about whether we're getting it right or not, just in terms of our priority areas?
So I've had some very early conversations with partners, and what we're planning on doing is, as we develop our strategy and get ourselves into a draft position, we'll come back into board development in early part of January, and once we've been through board development with that strategy, with that draft strategy, we're then formally going to go out to all of our stakeholders. So some of the early conversations I've had is actually with Health Watch and some of the other providers, but it is early days.
Great, thanks, Sarah. I've got Julie.
I'm Julie Atfield, I'm the Exec Director of Local Mental Health. I just wanted to respond, Manjit, on your point about the impact of social care staffing, you can see in the integrated performance report about delayed transfers of care in mental health services for older people. So the rate of delayed discharges is doubled actually in the last quarter. And the reason for that, cited from clinical staff, is the availability of placements to discharge people to. We believe that there are in the region of 20 or so local placements who have stopped taking new admissions into social care placements, and that primarily is about their staffing. So just to highlight that that's an impact for us, probably to the equivalent of one full ward in MESOP. So that's definite impact for us, and I think we also see that in the acute hospital pathway as well. So it's playing through definitely in terms of an impact there, Manjit. We have got escalation processes with the local authority and the CCG about trying to manage the impact of that and reduce those delays for people. And there's also the impact on care packages as well. So it's definite pressure.
Great, thanks for that, Julie. And I know it's one that you'll be keeping a close watch on to see if there are further impacts. Okay, well, thanks for that update, John. And I appreciate there's a lot in your report that we didn't discuss, but there's a lot going on out there. So let's move, if we can, to item 11, the Workforce Race Equality Standard, the RES, and the Workforce Disability Equality Standard, the WDES. Claire, over to you. I'm not sure if you may be interrupted with a phone call, Claire, or whether that's been sorted.
Shall I try? Is that
okay? Yep, try it, and if needs be, I'm sure John or a colleague can pick up.
Okay. So good morning, Claire Teeney, Director of People and Culture. We have the Workforce Equality Standard and the Workforce Disability Equality Standard paper here for the board. It's here for assurance and to provide visibility around some of the papers and work that we've taken through the People, Culture, Equality and Inclusion Committee. The RES and the WDES are both mandatory requirements under the NHS contract and also form part of CQC inspections. So they are important for us at an organisational level. They're also important for us in terms of driving key change. The reports provide an overview that in terms of the Workforce Race Equality Standard, we have seen an improvement in 5 out of the 10 indicators, with 2 remaining the same and 3 results that have showed that there is still the experience of BME colleagues is not as good as white colleagues within the organisation, and particularly that relates to the standards that report on negative experiences around bullying and harassment from both patients and members of the public and other colleagues within the organisation. So I think that whilst the improvements are good, it's important that we note the areas where there's still significant work for us to do. In terms of the aspirational targets that were set under the RES standard, we've exceeded those for both 2021 and also overall in 2022, which I think is also positive. In terms of the WDES, again, we've seen some positive improvements, and I think it's also worth noting that the number of colleagues that do actually declare themselves to be disabled within the organisation, whilst there is work for us to do on that, we benchmark well in that regard. So in a lot of other NHS trusts, for example, there's still quite a lot of underreporting from colleagues with disabilities. So I see that as a positive thing that people are able to make that declaration, and that helps inform some of the reports and the actions that we need to take. Overall, again, there are 3 negative areas that we've still got to address. So the report is here for assurance. It does go through and has been approved along with the associated action plans at the People, Culture, Equality and Inclusion Committee. And I think the action plans will be tracked there. The final 2 things that I did just want to say is that in terms of the action plans that underpin the RES and WDES standards, we do track those, but also I just want to express thanks to the BME staff network and the race religion steering group within the trust for also working really hard to co-produce the race equality action plan, the race equality improvement action plan, because the actions on there for me are important because they're the things that colleagues within the organisation are saying need to happen to make a difference to their experience. And I think that's significant, and that plan really is the one that, alongside the others, that we should pay attention to in terms of the progress that again will be tracked by the People, Culture and Equality and Improvement Committee. And also just to note, the final point was that our trust actions for last year's staff survey did actually and continue to focus us on improving the experience of BME colleagues and also disabled colleagues within the organisation. And as John said, we are out to this year's staff survey, but I think those actions and priorities are likely and will remain for us as a trust. Thanks, Paul.
Thanks very much. So just, I know that colleagues will have also had sight of those action plans in papers that aren't in our actual pack. Sue, can I start with yourself on this one, please?
Yes, thank you, Paul. My name's Sue Nixon. I'm one of the non-exec directors, and in fact, I've been asked to chair the particular committee that Claire has just referred to. This isn't actually a question, Paul. It's just an additional point to share with board colleagues. We did have quite an extensive discussion, as Claire has highlighted, at the committee. And I too would like to commend the work of the BME network and the Race, Religion, Belief and Equality Group, because that work has been co-produced, and it's not only just about this particular trust, but they've taken on board issues that need to be looked at across the system, and more particularly some of those points that have been raised in some of our initial discussion groups when we've been talking about strategy, is what do we need to do to make sure we address a number of these concerns back out with our communities as well. So we're trying to look at it down at the ground, within the trust, with partners at system level and also nationally. That's an awful lot of work. It's going to take time, but our own trust has also got a number of development groups, and I know Sarah across the far corner there leads on a work group on disability issues. So I think it would be very healthy to see the impact of that additional work and the improvement plan to see where we get to further down the line. And I would just commend everybody for their contributions at this stage.
For additional piece about that broader context. Steve.
Thank you. Good morning. Steve Banks, non-exec director. I've got two questions, please, if I may. And apologies, I didn't raise them at the People Committee, but they've come to me later. So the first one is, often when we're looking to improve things, we have a lot of lead indicators, but we have to get focused on the outcomes. This feels almost the other way around. We have a lot of outcomes here, so we're looking historically about where we've moved. Clearly, there's a very comprehensive action plan that I thoroughly commend. Is there any way we can develop any indicators from our work on values and behaviours? Because underlying all these outcomes, although they're improving, they're still not acceptable, in my opinion. So is there anything that would enable us to measure if our work on values and behaviours is actually moving us in the right direction? Is one question. Sorry, I can't see you, Claire, but
Great.
I'm kind of addressing it in your corner.
Do you want to give your second one, and then Claire can respond to them both, Steve?
Thank you. And the second one is just an ambition. So looking at the improvements on the plan, so this is about the RES more than the RES and the DES. First question is about both. So we have a table on, I can't see the page, sorry. Page 31. We have a table that shows our ambition, and in fact we've overachieved in terms of having somebody from a BME background at band 9. But why don't we have an ambition to have somebody who's a very senior manager? And if it's not this year, when will it be, please?
Claire?
Thanks, and thanks, Steve. So in terms of the first question around improvements and outcomes, I think that what I would say is we can always set our own. What I would point us to is the National Staff Survey, and actually the way that we cut the data, and I'm happy to share that separately, and that actually shows where we need to focus. And I think if we read the narrative that comes in alongside the statistical responses to the staff survey, that shows the things that we've got to do and work on to improve experience and outcomes for all our colleagues. So I think that for me, rather than create new things, I would encourage us to stay focused on shifting those responses and that experience of colleagues, because they are the things that will give us a level of point quite rightly to the things that we do need to do differently. An example of which is that for disabled staff and people with long-term conditions, they do not feel that they are supported properly with reasonable adjustments at work to do their job properly. That's a very tangible thing that we could pay attention to that would improve the outcomes in terms of experience for colleagues. So I think the information's there. I think that we just need to perhaps make it a bit more transparent, and we need to focus our attention on it as an organisation, which we can do through the committee. And I also I support what you're saying around the ambition. And we've had a conversation around that both at the board and also at the committee, and the executives are currently working that through to, I suppose, set out what might be the things that, albeit they're the national standards and expectations, but what do we, or how far do we want to push, and do we realistically think that we can go as an organisation on that? And we will bring that back. So it is there, and it is work in progress.
Steve?
Thank you, Claire. No, that's great, Paul. Thank you for those answers.
Great. Manjit, can I come to you, please?
Yeah, thank you. Manjit Darby, Non-Exec Director. I think this paper is about three things for me. One is, do we have a workforce that is representative of the people that we are looking after? Secondly, are we looking after that workforce? And thirdly, does that workforce have equal chance when we employ them? I think that what we're looking at in this paper is that we're making some progress, but we are still struggling in some significant areas. I think the issue of harassment and bullying at both the res data and the des data tell us that we aren't getting it right. So I think that the issue of ambition is a really important one for us as an organisation. I know at the People and Culture Committee, we've had a detailed discussion and in our development session about what is the level of our is acceptable to us as a board, as an organisation, in relation to the progress that we want to see. And then finally, the impact of any actions that we're taking and whether that is delivering the change that we want to see. I think this paper tells us that we're getting bits right, but I think we've got a long way to go.
Yep, that's great. Thanks, Manjit, and I'd certainly endorse that take there. John, and then I've got a couple of wrap-up comments myself. John.
Yeah, thanks. Concur with Stephen Manjit's view, and just yesterday actually talking to Claire about setting ourselves some clearer objectives around this agenda, using that pathways to excellence methodology. So, you know, what is our ambition here as a trust to do those three things that, for example, Manjit's just emphasised there. What methodologies are we going to use, and what measurements include, whether it's National Staff Survey or the RES, etc. But what are we going to use to inform us of our progress? And we've penciled in an exec team timeout conversation on this, and then we'll bring some worked up drafts for a board development session to really start to nail that into in the early part of the new year.
Great, thanks for that, John. So I think in summary, Claire, I think absolutely share that we mustn't lose sight of the fact that there's been a lot of progress in a number of the areas on both the RES and the WDES, which is good. I think we've heard there as well that we need to, and I don't think we heard any of it, we need to make sure we avoid the complacency that can come in organisation for a lot further, and that includes in some of the ones where we've made good progress. There's still a lot more we need to be doing, and I think we've highlighted particularly that some of those some of that data around harassment, bullying, and discrimination are ones that they go beyond just our processes. I think as Steve and Manjit were highlighting there, they do then get into our values and our organisational culture. Personally, I've been pleased to hear of that ambition commitment, and I know that we have got board development time scheduled. It's something Sue, as chair of the committee, wanted to make sure that we also brought forward, and I think there's a strong sense here, Claire, of us being able to really wanting you to be able to come and challenge us further around our ambition as a board. And just to finish by again thanking those networks and groups who've supported that co-production work, and I know they will need no reminding, but a part of what they are able to do is also challenge and hold us to account, which is a really valuable piece of the picture. So thank you for that, and we'll receive those reports and indeed the action plans that went alongside them. So if we could go now to item 12, which is the Safeguarding Annual Report and Declaration. Anne-Maria, please.
Very much. So you can see you've got your...
Could you use your microphone, Anne-Maria?
Can you not hear me? I have to pick it up.
It's for everybody else. You have to pick it up. Yeah.
You have to pick it up. So you've got your paper copy on your tables, which I'm really proud to present. I think it's set out really nicely. I have shared it with some partners, and it went down very, very well. It's also been to the Quality Operational Group as well, and it's also been to the Quality and Mental Health Legislation Committee. So it's done the rounds and very, very well received by everybody so far. I'd like to take it as read, and in the reading room, you've got the performance details as well, to be able to ask any questions anybody would like to ask.
Okay, thank you very much. Are there any...
Shouldn't I? So sorry.
Do you want to introduce yourself now?
My name's Anne-Maria Newham. I'm the Executive Director of Nursing HPs and Quality.
Just getting to grips with having to use a physical microphone there, Anne-Maria. So any comments or questions on this? As you say, it has done the rounds through various parts of our assurance processes and has had thorough scrutiny. Okay, I'm not... apologies, Stephen.
Thanks, Paul. Stephen Jackson, Non-Executive Director. I just want to say it's a really good report and very well set out. Thank you.
Thanks. Steve, please.
Thank you, Steve Banks, non-exec. Absolutely echo that, the report and the detail in the reading room. This feels like an area that is always very assuring when we talk about it. Of course, it's an area that's always very fast moving and difficult to keep on top of. I guess I challenge myself or all of us. It's a kind of fast moving environment, safeguarding, and we respond to changes. And forgive me if I've missed it somewhere. Is there room for us to be talking about this in our strategy development for the next 5 years, in terms of where do we want to be? So is it already built in? Will it be part of the process? I know I should know the question because I'm chair of the strategy committee. And is there any room for us to kind of even get ahead of the game here? Because it seems to me this is something that we seem to do really well without being any complacency about it. Could we be even better and more forward looking?
Yeah, I think it's a really good question around the strategy in the next 5 years. But what I see is safeguarding is everybody's business and everybody's job. So I wouldn't want to isolate it out and see it as a separate component to anything. I think that everything we do, say for example, whether it be people, whether it be quality, finance, everything we do is around providing that safety mechanism that we have in place. So it is within the strategy with regards to quality and keeping people safe, and that's what this does really. So in answer to your question, it is considered throughout, but we don't take it out as a separate thing.
Yes, I understand it. I kind of absolutely agree with where you're going there. I suppose what I was trying to tease out as well is there almost a different ambition, or do you think that will be recorded within that? How would we like it to be so much better in 5 years? Does that come through, you think, Anne-Maria, in the...
I'm not sure I can answer the question really. Yeah, I think that with regards to safeguarding, because it is so fast moving, something might be really different next year, depending on what it is. We're really responsive to what happens. Yeah. So for example, we've seen an increase in domestic violence, we've seen an increase in homicides, we've seen an increase in children's mental health. So all of those are considered as we move along, and anything that we do really.
I think I'll just take the assurance that it is built into the strategy process, Anne-Maria. Thank you very much.
I think there's a good challenge that you bring, Steve, and perhaps your committee can just keep an eye on this. That is that we remain as agile as we need to be, as you put it, as far ahead of the game as we can be, notwithstanding, as you say, Maria, that there's a lot in this sphere of work that we have to respond to.
So the only thing I could add is that I also encourage external independent reviews of services such as this. So we've just had one this year, and I would always encourage every 3 to 5 years to have that independent review that looks at all the external guidance, national guidance that we should be following, and making sure that we are doing what we should be doing. And that's been assured this year fully. And again, in 3 years, 5 years time, we would do exactly the same again.
Steve?
Thank you. And I'd just like to come back with the context I started with. I think this is something that we're really good at and could be national leaders in. I think we kind of already are. So there's that responsibility to keep trying to be even better, but please take it in the spirit that I feel, you know, really, really assured, and we have a great team on this.
For example, the sexual safety work that was led by us as a trust nationally, and we are a case nationally. So you're absolutely right.
Great. Thanks very much, Anne-Maria. So we received that with absolutely getting the assurance that you've sought there, and a degree of enthusiasm as well about where we are positioned on this. And I think a good commitment there from the strategy committee to play its part in making sure that this works forward. So if we can stick with you and move to the infection prevention control annual report, please.
Yeah. Sorry, I don't have a paper copy for you today, but we will be producing one for some of our events that we are doing. So this is our annual report, and again, I'd like to take it as read. However, I just wanted to say a couple of things. That IPC has been a challenging time over the last 18 months. I think it's also come to the forefront. In a way, it's benefited us because it's really put it on a kind of like pedestal to know of your infection prevention control measures and what you've put in place. I would like to say that I think the team and the trust stood up really well during this last 18 months, and we've maintained really, really good practice. Yes, we did have outbreaks, but that's to be expected, and so did everybody else. But everything we did was responded to really well. We were congratulated in how we managed the outbreaks as well nationally. And we had a lot of scrutiny from the external world when we did that as well. So unusually, the IPC annual report wouldn't be so heavy on pandemic stuff, but of course, this is what you will see in this report this time. And you will also see some of the data as well in there. So just to take it as read, but happy to take any questions at all.
Thanks very much, Anne-Maria. I've got a comment to make, but I'll just see if anybody else wants to come in before me. Manjit.
Yeah, thank you. I mean, I absolutely echo the work that the IPC team have been doing. My question relates to the lessons that we've learned as a result of the pandemic and how that plays out into just looking at the detailed annual report in the reading room, and how we are making sure that the lessons that we've learned play into either our requirement for funding, changing the way that we manage the estate, and also the resource that we put into IPC moving forward, and making sure that we are tracking that, because the issue of IPC resource going forward isn't going to go away, is it? So it's just an assurance about kind of the learning that we've done, embedding it in practice and seeing the changes happen.
Yeah, and I suppose that's where I went back to a little bit with regards to the fact that actually it's done us a favour. It's put it out there, and it's shown people what's needed and the resources that are required. Last year we did actually put a business case forward, and we did get some additional into the infection prevention control team, which is why probably we've been able to manage it as well as we have done. With regards to the learning, we're actually doing a big piece of work. One of the IPC nurses, Katie, is currently doing a review of every nosocomial death that we've had since March 2021. So we've had another 2 deaths actually this week, and that will be put into a big review that we're doing. We also are awaiting some of the work that we will have to do with regards to the national review and inquiry that will be made into the learning that will come from this as well. So we've already gathered as well, and Becky has done some work with the incident control team, who have done some gathering of all of the information that we've done so far with regards to our response during the COVID outbreaks.
Anne-Maria, could you just remind us all what nosocomial means?
Yeah. So nosocomial is an infection that a patient receives or gets or acquires post 8 days in the hospital. So it basically means that the patient has acquired it through ourselves, not coming in from a community acquired.
Thank you. Manjit, did you want to come back?
Yeah, I mean, I'm just interested in the impact for us as an organisation, particularly on estate. You know, we're sitting in a room this size. Well, actually, if we're going to carry on with a distance approach to meeting in person, for instance, what does it mean in terms of the estate requirement and the capital requirements moving forward, the office accommodation that we have, and kind of making sure that we manage IPC safely for the longer term, and how are we playing that into the conversations about estate and capital?
Yeah. So, I mean, I'll hand over to Lorraine in a minute, but just to say that we've been heavily involved in all those estate questions, particularly around ventilation and that bed spacing that we've been required to have. It has been a huge challenge for us. We've met most of the requirements, but there are still times that we've not been able to do that due to the estate and how old some of the estate is. With regards to resourcing that, I think that's still a conversation for us to have. But I'd be happy to hand over the space utilisation team. Done a fabulous job. And I'll hand over to Lorraine.
Just before I invite you in, Lorraine, just to flag Carolyn, you may want to comment on this from the scrutiny and assurance of the Quality Committee. But Lorraine first, please.
Thank you. So Lorraine Hooper, Director of Finance, Information and Estate. So as Anne-Maria referenced, the space utilisation team are working really closely with all the clinical and corporate services at the moment on what we're describing as reform. So what do we think the future looks like, and how much space are we going to need? And that will feed into our planning alongside all of the other things we've got to do around estate planning, backlog maintenance. And the other bit I would add as well is the dormitories work. So the significant programme of works we've got over the next 4 years to eradicate our dormitories will help enable better estate for a whole host of reasons, which IPC will be one of those as well. So I can't say we've got all the answers, Manjit, I can say we're working on it.
Right, thanks, Lorraine. Carolyn.
Thanks. Carolyn White, Non-Exec
Director and Chair of the Quality and Mental Health Legislation Committee. Paul, in answer to your question, that the committee weren't able to discuss the actual annual report just because of timing issues of committee, but we did receive it virtually and have reviewed it and offered any suggestions back to Anne-Maria and the team. So it was reviewed virtually, if you like. But in terms of assurance, we do receive regular reports around infection prevention and control. It would be fair to say I don't think we have taken anything specifically around estate issues, other than the normal things such as Legionella, but an issue that we want to consider going forward. Thank you.
Great, thanks for that. Anne-Maria, anything else you'd want to add on this one?
No, thank you very much.
No, it is really important. My only reflection was that just that point about the need for us to hold really close watch on infection prevention and control as we move into winter and through winter is even greater than usual. And certainly for us as an organisation, but for all of us in our individual lives, I know this is incredibly wearing. And I just really want to encourage everybody, not only here, but all of our staff and teams, volunteers, indeed everybody out there, that as we move into winter, and I know that quite rightly there are going to be opportunities for various celebrations and things like that, and just a big plea that we really do try and hold on to the importance of strong infection prevention and control. It's a way of enabling us to have those good celebrations rather than getting in the way, and I think we'd all rather have those strong celebrations safely than the impact of not doing so. So it's just a personal plea there, Anne-Maria. So I know our next item is the integrated performance report. Given that it's usually quite a chunky item, I'm going to suggest that we take a short break now and restart at 11 o'clock if we can, please, just so that we can have an appropriate comfort break and then restart and come in on the integrated performance report. So we'll just pause for about 12 minutes. Thank you. Okay, folks, if we get back to the table in a couple of minutes, please. Okay. If we can just get ourselves back together. I know there's a couple of colleagues still getting back into the room, but let's press on if we can. So we'll go to item 14, our integrated performance report. Lorraine, over to you to give us your usual steer through, please.
Of course, thank you, Paul. So the integrated performance report that you have in front of you is up to and including the end of September. And I think you'll see as we work our way around it that some of the operational challenges that we've been talking about throughout this meeting are quite clear in the IPR, and I'm sure will come out as the relevant directors talk through. So we'll start with quality and Anne-Maria.
Yeah. Let me just get the right page. Okay, so we're on page 68, and the first one there is around the friends and family test. You can see that we've had a dip, which we were expecting in reporting, but the database basically is telling us that we've had a significant event, which is the drop in September 21. So showing that from end of October 2019. We have spoken to the patient experience and involvement team, and they're doing some work around how to innovatively retain and receive information in different ways. They're doing some really good work with volunteers as well to ensure that we can get information, and we're using care opinion a lot more as well. I have the second item is around hate incidents. I've brought this to the board for the last 2 or 3 occasions. We're continuing to see an increase. You can see there September 21, we've got those 150 there on the graph, which is on page 12, page 69 of your report as well. And that's basically because of much better reporting, much better awareness, and we're doing a huge campaign around the organisation. We've done a really great poster campaign to make sure that people are not just reporting, but they know that something will also be done about it. One of the things that we were finding with staff is that they thought there was no point in reporting because nothing would actually be done about it. But what we're showing is that you said and we did is really important in this area. Actually, I think I've got behind me Robert, who developed the work around hate incidents, and I just would like to say thank you to him. It's enabled us to have a better understanding of what goes on in the organisation. He's done some great work on that, Robert Mookin.
We've also got the pressure ulcers, which again has been to board a couple of times. We can see that it's within acceptable ranges, but it's still high. And they've done some really good work in CHS, Community Health Services, with regards to the pressure ulcers. Nationally, this has been seen as an increase because we think that the elderly and frail have spent more time being immobile because of COVID. But we are doing a big piece of work and we've reviewed it as well. And then safer staffing. I think that it's safe to say that we've had a huge challenge in ensuring the wards are safe with regards to the numbers of staff they have. I would like to just say that we do an establishment review twice a year. It's a requirement from the National Quality Board, and we've done that for the last 4 or 5 years. We've also presented to the board previously if there's been an increase required on establishment requiring funding and support. We've just done another one across adult mental health, but it's very difficult because we've not been able to necessarily recruit to the previous establishment review recommendations. So we do see here rates less than 85%, which is really poor for us because it means that we're not able to fill the wards with the amount of staff that they require in order to look after the nature of the patients that we have. There has been an increase in acuity. And there's been a drop in qualified, experienced Band 5s and Band 6s across the wards. We are very reliant upon bank and agency at the moment, and we thank them for doing the work that they do, but it does mean that we have temporary staffing across the wards, which is not ideal. So that presents there with regards to the areas that are of concern for us. And I think that's it. Handing back over to Lorraine, happy to take questions.
Take some questions. Trevor, you caught my eye first. Trevor.
Yeah, Trevor Orman, Non-Exec Director. Anne-Marie, it was more just a simple assessment of how do we stack up against averages of other trusts? Are we out of line, out of kilter, or are we in family across the areas that we've just covered?
With regards to staffing or of the other areas, Trevor?
It was actually a general question against all of the areas, but particularly against staffing. Yeah.
We know that we are the same with regards to pressure ulcers as the same as other areas that we've benchmarked ourselves against. We've looked at Lincolnshire and also Derbyshire with regards to some of the benchmarking that we need to take on, particularly around safe staffing. We've also contacted them around some of our community health services as well, because we know that they're equivalent to us. With regards to safer staffing, on my conversations with all the chief nurses in equivalent organisations is we are really, really struggling. We're all in the same boat and we're all scrabbling for the same staff, and we've all got rolling adverts out there and we're all trying to be as innovative as we possibly can with new roles and different ways of working, and also working hard with the universities as well to ensure that we get a good supply from the universities, but we are all in a similar position.
Thanks, Anne-Marie. John, I think you want to comment on that as well.
Yeah, just to emphasise that point. Oh, am I on? Just to emphasise that point for the board, really, it's a theme. For example, in my report and the IPR part that Anne-Marie is talking about there, that we use the word unprecedented a lot, but the point we're at with staffing is a real concern for the executive team. We're having regular updates and conversations about the sorts of things Anne-Marie has alluded to in terms of what can we do to mitigate against this, and there's not a single solution. We're at the point of thinking, okay, so what potential non-ward services can we look to move staff from to help? We can't rely on the bank and agency because they're being hit similarly in terms of numbers, and we're at mission critical. We're not alone, Trevor. it's across our links across the East Midlands and well, I suspect nationally too. But just to really put that as a red flag, and we'll probably have some conversations through the board today that that go into more detail on this. But it's a situation we're in, and it's a real worry for us.
Thanks, John. Trevor.
It may seem a bit of an obscure question as well with this, John, but has the EU had a dramatic effect on our ability to get the staff in, or is that something that, because it doesn't get mentioned much in the press that I see these days, that it's almost like you've got what you've got, so get on with it within the UK.
Claire,
does Claire know the answer?
Claire, do you want to give a response to that, Claire? And then...
John, you might want to say a few words. I'm happy to.
Well, I was going to say I don't think it would have had a huge impact here. We didn't have large numbers of EU people working in the organisation. It might have contributed a few, but from an organisation trust perspective, you know, that it's something else that hasn't probably helped, you know, because we value everybody's contribution from wherever they're from. But I don't know whether Claire's got more detail.
Could you use your microphone, please, Claire?
It's the wider impact on the labour market. So I think it's the indirect effects of the other things that are happening. So there's been a greater impact in social care than was accounted for and noted. That has an impact, and also you'll have probably picked up in the news about wider labour market issues, whether that be about drivers, transportation, other service staff, and all of those have an impact on the services that we provide, both in terms of labour supplies and other things. So I think we are seeing of it, even if it's not been our direct workforce.
Thanks for that, Claire. Just to say, John, on the back of your comments about the real the red flag there, I know that non-executive colleagues share the executive team's real concerns on this and are keen that we do whatever we can as part of this unitary board to support any actions that you think are the right things for us to be doing. Manjit.
Yeah, thank you, Manjit Darby, Non-Exec Director. John, I just wanted to pick up on your point about kind of where the tipping point is here, because actually it struck me from the IPR that we've got some real areas of concern. And just going back to what Julie was saying about, you know, the kind of the backlog in terms of getting patients out into care homes, the build-up of pressure on the other side, the increase in levels of sickness and vacancy levels. If you put all of that together, you're talking about kind of, you know, how do we manage it going into what is going to be a difficult winter? Kind of what's the thinking in terms of kind of what the tipping points are going to be in terms of, well, actually we need to move into major incident territory, or kind of, you know, how do we protect the staff going into what is going to be a really difficult 3 months, 4 months? So I'm just interested in your kind of thinking as an exec team on where that's going.
Yeah, thanks, Manja. I think it's probably true to say we're at that point, really. Like you say, whichever metric you look at, and that when you then triangulate, you come to a pretty similar conclusion, really. I mean, it's not all services across the board. There are pockets where it's more concerning, but wards particularly, across all divisions have you noticed that, you know, the deterioration in staffing numbers, as you can see within the performance report. In answer to your question, I think the executive senior leadership teams have already got, you know, some good processes in place that have tried to head this off at the pass as we've seen it come in. So we've got incident control team meeting regularly. We're looking at making sure we've got the rostering processes, looking ahead and making sure we've got services covered. But and I suspect this is the tipping point, is that those usual processes are having less impact. So despite that, you know, I'm getting emails from staff, not all the time, but, you know, 2 or 3 a week saying, you know, thought I'd better let you know that this is the situation here. So we've prioritised some time at exec tomorrow to drill down and to start to pick up some of those questions that, you know, have got tricky answers to. Okay, so if we're going to prioritise inpatient services and crisis response, what's got to give? What's the least worst option on a balance of risks? What risks are we more likely to be able to tolerate compared with others? And make sure that we communicate that, or, well, that we work with our staff to develop the plans, because a lot of them have got some good answers. So the engagement and comms piece with staff's important to keep stakeholders and particularly regulators updated on where we've got to.
Right. Thanks, John. It's very challenging. So just a couple of comments from me and Maria as well, just to say, acknowledging in terms of the hate incidents piece that, again, you're confident that the increase that we're seeing is because of improved reporting, but I just wanted to just also remind us that obviously that's 150 incidents of hate crime that we need to be aware of, and that's the real experience of some of our staff. And I think it's great that we're getting better data. It just raises the importance for us as an organisation of being able to support staff and challenge those unacceptable incidents as they come through.
I'll just say, yes, it is. It is definitely around awareness,
yeah,
rather than a massive increase in the hate incidents themselves occurring. And we've commissioned a piece of work by Communities Inc., who are helping staff to really be able to address some of those things for themselves when it happens, and pre it happening as well.
Great, thanks. And one was just to take away as a technical one around the new pressure ulcers. We've gone 7 months now, whilst we're still within the acceptable limits above the line. There may need to be a bit of reflection on, are those variances set at the right levels? But I'm sure that's the kind of technical stuff that you're on. So thanks. Lorraine, do you want to move us on?
Yeah, absolutely. So we'll move on next to Claire and workforce.
Thanks. So we've touched on, in terms of some of the conversations so far, some of the capacity issues that we've got. I think the things that I would add to that, they are affected by underlying sickness absence, COVID absence and precaution. The thing to note is that we've been running at that level of absence affecting our capacity for some considerable time now. So that's not a usual set of circumstances either. We'd normally see a rise in absence during the peak winter months of sort of January and February, but consistently we've been running at higher levels, and that has an impact on people's ability to cope, to be able to manage when they are in work. So when I say capacity issues, it's not just about looking at the people that are not able to be in work. It's also about thinking of the capacity of our colleagues that are in work to be able to discharge their duties and be as well as they can be in terms of doing their job. And I think we're also seeing that as an impact as well. We have got support mechanisms in place as far as possible to support that, and we are just in the position of launching our winter wellbeing programme. But as we've described in the recent conversation, it is a difficult set of circumstances, and it's compounded because it's not contained, as we've just articulated, to our own trust. It is more widespread, and therefore it has an impact on our services. And we are working with social care colleagues to try and come up with some joint solutions around overall capacity and workforce, because as it stands at the minute, if we try and recruit in health, it just strains social care because people come for those jobs because of the terms and conditions. So we get into a circular position of not resolving the issue but compounding it. So we are working across the system to try and work that through. Couple of other points that I just want to bring out. As I say, we've talked about the health and wellbeing offer, which is good, and colleagues are supporting staff. In terms of appraisals, we did derogate from doing appraisals, but did have a reasonable plan to get those back on track. And we are seeing a steady increase, that is a planned increase in terms of appraisal uptake, which is good. In terms of the overall vaccinations, one of the things that I would just want to highlight is the work that we've done around the school age vaccination programme as a trust. So the schools, IMS and VAX team within Community Health Services were responsible for taking forward that programme of work initially into a programme across 40 schools across the county. They've done a really good job. To date, we've got over 10,000 school-age children vaccinated, and now that programme has opened up so that we continue to go into schools. That will cease soon, but school-age children can book on via the national booking system into vaccination centres and the hospital hubs locally as well to receive their vaccination. So just want to express thanks to what is a team of circa 8 people for a really excellent job on the school's vaccination programme. And finally, just to add, we've had over 93% of colleagues that have been vaccinated for COVID. That is a really good uptake. It benchmarks well, and we continue to work with vaccine hesitant colleagues to receive the vaccine. And to date, we've had over 3,000 colleagues that have received the booster vaccination as well. And we are seeing a really good response to people, i.e. not needing much encouragement at all to get their booster vaccination as soon as they are eligible. So I think that that's really, really encouraging. Thanks, Paul.
Just pause to see if there are any comments on that. Trevor.
Yeah, some obviously some really good signals there, Claire, which is really encouraging. But just picking up the point that Manjit was making about the compound impact of some of the issues that we're seeing. Do we do a what if the trend of sickness, and we haven't hit the winter period, if the trend of sickness goes up 3 or 4%, and if another 1 or 2% of people leave or whatever, then the impact that, doing a scenario of the impact that could have on the trust, so that we're on the front foot as opposed to the back foot. I'm not suggesting we don't do it, but I'm just asking the question as to the thought process behind it, Claire.
Yeah, so we do that, and that came to the fore actually last winter, Trevor. It was a more, we always know there's seasonal variation, and we always plan for that, particularly as part of the winter plan we have as a trust and as a wider system. And last winter we did do some more detailed work around that, and we're just in the position of doing exactly the same. John alluded to a extended conversation that we've got tomorrow. We're well versed in, I think, the issues that we're currently dealing with now, and we're looking at how we manage those. But we have done some forecasting around what that can look like, particularly going into December, January and February, so that we can inform some of the actions that we may need to take around services, staffing, all of those sorts of things. So yeah, that's all in hand.
Right, thanks. Carolyn.
Thank you, Carolyn Mike, Non-Exec Director. Claire, can I just ask you about lateral flow testing? Because whilst we've reported there 239,000 tests have been done, that seems like a relatively low proportion given the numbers of staff we had. And I just wondered what we're doing about kind of driving that down to local management in terms of their responsibility to reinforce the message of doing that with their staff.
So I'll see if colleagues may want to come in, both Anne-Maria and Lorraine. It has been one of our more thorny issues, I think, to deal with in terms of lateral flow testing and the reporting of. And we have supported that by the development of some of our systems so that local managers have got access to information around their tests. But if I can hand over to Anne-Maria.
Yeah, I'd be happy to take some of that. So up until about 3 months ago, ward managers weren't able to see what their own staff were reporting. So we've now, they've got the capability, each ward manager can see exactly who's reporting, who's testing, how often, if it's daily, if it's weekly or if it's twice weekly. If we have any outbreaks, that's drilled down, and the incident control team are brilliant at telling us exactly who has been testing, who's reporting. So we do have all of that information. On a weekly basis, Yolanda puts that out on the comms messages to all staff as well, to remember to do their lateral flow testing as well as reporting. What we're finding, and we've got evidence of this, is that staff are doing the testing. They're just not great at them recording it, so we don't have those numbers recorded. But we've done so much work in this area.
Carolyn, is there anything you wanted to add to that?
No, I mean, it's reassuring to hear that the ward managers can see what's happening in their teams now. So I guess it's about local performance management, isn't it? And seeing how that starts to improve. So thanks, Anne-Marie.
Right, thanks. It just underscores the point I was making about us working at keeping on against that kind of pandemic fatigue that people are feeling. It's really, really important. Claire, do you want to add a final comment before we move on?
Yeah, it's just a final comment that, and we'll be discussing it a bit more tomorrow, but I'm also really conscious of the amount of additional ask that there is on key clinical staff, for example, our ward managers, and around information that they have to navigate, whether that be about lateral flows for staff, swabbing for patients, all sorts of things. And one of the things we started and will be further considering is how support services and non-clinical staff can actually start to help the clinical managers manage some of that in their areas, because I just think we're asking quite a lot of them when they've got capacity issues on the ward and then additional things to manage. And I think we need to think about some different modelling about how we enable people to be able to do that and comply with the very things that you're saying, Paul.
Thanks very much. Lorraine, can we move on to our next part, please?
Yep, so we'll move now to our 3 operational divisions, and we'll start with mental health and Julie.
So I'm Julie Atfield, I'm the Exec Director of Local Mental Health Services. I'm not going to repeat the comments made about staffing, but just purely underline those really, and their obvious impacts. I think this performance report for local mental health gives you a sense of the pressure and demand on services. Referral rates have restored in all services to pre-pandemic levels, and in some cases increased by 20%. And coupled with that, we've got a high level of acuity in our inpatients, and obviously issues now around discharge of patients, and particularly what we see is quite high numbers of patients breaking down in their current care placements, and then the mental health route being used as a consequence of that. So we got those kind of pressures at the front door. You can see, I think, the work around waiting starting to have some impact actually, and internal treatment waits have stabilised, and we're starting to see those reduced. You can see in the performance report where we're using other capacity through either the third sector, other provider organisations, or through the subcontracts to try and reduce some of the impact on our services. And I think that sometimes it's difficult to, when you're, coupled with some of the operational challenges we've got, to pull out some of the positives. But I think the community waits is a positive indicator of some of the transformation work starting to hopefully impact. We're having to, though, focus then the same level of CAMS waits, which is a pocketed challenge for us in specialist services. And I do feel for the board to have some more insight into the overall numbers of people waiting. Any internal waits, I think, would be a good input for the board at some time in the next couple of agendas. I do want to pull out some positives because there are some. We had our GIRFT review, which is getting it right first time, for our acute and crisis pathway in October. It was chaired by Ian Davison, and he's the national lead for the GIRF review. And he actually described the transformation of our community and acute pathway as remarkable, which, you know, in the current set of circumstances was a really nice thing to hear, and was really complimentary about the community transformation. But that we had managed to sustain some of the improved performance around out of area. So I think that was good to hear. The out of area trajectory has been revised and approved by NHSI, NHS England, and they're comfortable with the actions in our plan, and do understand the challenges that we're facing around that. And we've got a particular surge at the moment around male psychiatric intensive care. Another positive, there are some actually, you do need to keep that mindset, I think, about some positivity, because our early intervention in psychosis service, which was quite a troubled area a couple of years ago, was less than standard of level 1 in terms of NICE compliance. Should be at the expected national level of 3 at the end of the year. So that's a massive transformation. So we're still holding on to a level of optimism about some of those developments, which I think is important, notwithstanding, you know, the current pressures that you can't deny around staffing. So I think I'd put our performance in that context, really.
That's great, thank you. It is a good reminder for us that, notwithstanding, it's quite right that we focus on challenges, that we also just take that time to acknowledge some of those achievements in the midst of it. Let's pause to see if there are any comments on this piece. Manjit?
Yeah, I mean, I think that the report gives us a really clear sense of grip on kind of what the position is for mental health services, and I think that's to be commended. I was just wanting to just explore the issue of our subcontract arrangements to manage some of the pressures, particularly going into the winter. I don't know, in terms of the wider commissioning arrangements, kind of what those conversations look like, but for us internally as an organisation to manage some of the conversation that we've had about the increased demand, but also the capacity issues with staffing levels, whether we're fully exploring and exploiting the opportunity to subcontract to the full.
We are doing, Manjit. I think the range of opportunities changes though constantly, because, for example, we do have pots of discharge funding, so we're looking at step down providers with new opportunities, new care packages, new funding, and at the same time we're able to, for example, increase the capacity in CAM psychological therapies through third sector online providers. So the range keeps expanding, and I think that in some of the what the contingencies are, there are still opportunities for other providers and third sector colleagues to do more, and I think that's something we will continue to do. But as our experience and our relationships with providers grow, it does allow us a great deal more opportunities. I think there's probably some more strategic conversations about how we might choose to place ourselves in the future, in terms of our strategy around some of that. I think there are good providers and partners out there that we might want to work more closely with.
I think you can take some encouragement from us, and I'm sure through the strategy committee, if there's a conversation that would be helpful to have there, that would be welcome as well. Okay, Lorraine, do you want to move us on?
Of course, so we'll go now to Becky, Sutton and Community Services.
Thank you, Lorraine. So Becky Sutton, Director of Community Health Services. So I'll take the report as read. Just a couple of bits I wanted to highlight. Some similar themes that we've heard throughout this morning in terms of pressure on our urgent care flow. So you'll see from the report, we have seen the length of stay at Lingsbar Hospital, which is our rehab area, increase slightly. I think that's twofold, really. I think it's as a result of the system pressures and the impact on local authority home care providers, but also we did have an outbreak there, so you do find that length of stay increases a little bit, and there's probably a little bit of an increase in acuity because of our acute providers that have constantly been on OPAL 3 or OPAL 4, so the highest level of response over the last month or so that does impact on where we're at. The other result of that is that balance that we've talked about this morning between the planned care and the urgent care response in community. So you will see that our 13-week wait referrals have increased, particularly in our planned care therapy waits. So that's directly as a result of moving our having a smaller workforce in our therapy group, so we've got vacancies within there, and then moving the staff around to focus on supporting people out of hospital, which therefore then means the planned care waits go up. So it's a constant balance around where do you move staff from, what's the impact, and what might happen to those patients if they're waiting longer for their treatment, because sometimes they end up back through the front door of our acute providers if we don't manage that well. What I am keen is, though, that we've got the weights out there. They're part of the system transformation plans, and we've got access to some monies around elective care recovery. So we don't hide those weights because they're just, as important as some of our acute providers. To link with Julie, there is some positives though. So what I have reported in the IPR this month, I spoke about a couple of months ago, is a new community response indicator that actually is in shadow forms. So we're not to deliver this until April of next year. But what I am pleased to announce is, so this is a service that manages people in the community as a result of stopping them going into acute care. So we have a target to respond to those patients, to assess them within 2 hours, and then to start reablement service within 2 days. I'm really pleased to report that we're already achieving 93% of our patients were seen within 2 hours, and 100% from a reablement point of view within 2 days. We've added the numbers in as well, because I think that target sometimes can feel like it's 1 or 2 patients. It's 191 in a month. So that's 191 patients that would have gone into an acute provider. So I think whilst we focus a lot on the back end of the process, the more and more we can do to manage the patients in their own homes and stop them going into acute care is where the strategy needs to go. So I'm really pleased to announce that, and we're ahead of the time in terms of some of that. The other bit just to report on, so I've talked for a long time that we lack quite a lot of outcome measures in community services, but actually we're just undertaking a big piece of work as a system around transformation of community services, and we're starting to have some really great conversations about local outcome measures for people and citizens at a local level. And we have got a slot on the strategy agenda this month to bring you as the board up to speed on some of that work and some of the thinking so far. So watch this space, and I hope to bring back some slightly more outcome focused measures in the future. Thank you.
Great, thanks for that, Becky. And I think you've highlighted just more consistency in some of the challenging themes that we've got, as well as rightly just pointing on a couple of highlights there. Okay, I'm not seeing any indication. So let's move on to, we've got 2 more bits to go, I think. Lorraine?
2 more bits to go. So penultimately, Forensics Division, and Sue.
Hiya, Sue Elcock, Forensic Director and Medical Director. So in terms of the IPR, what's always reported about forensic is focused around beds and occupancy levels. And I think as time progresses, we might need to just think about what is meaningful in the new sort of provider collaborative world. So occupancy remains low across high secure. What's of impact, though, in terms of that is that we've got waiting lists in the LD, the Learning Disability Service, and we've got full beds in. So although it's shows across the hospital as underoccupied. It's in particular pockets causing us different pressures. So we're working through what that looks like. Medium secure, particularly Wathwood Hospital, as is reported there, again is under occupancy, and we're working with provider collaborative colleagues on what is the clinical need now looking like and what the services need to look like to support that. In terms of delayed discharges, again, you can see that those are present in terms of high secure. There is a fortnightly meeting with national commissioners involved to look, and they support both the prioritisation of the front door, but also support out of the back door, so to speak. In terms of Arnold Lodge, again, they're just starting to see a slight increase in delayed admissions, and they're working through that. And some of these have been impacted when there's been COVID outbreaks as well, in terms of planned dates having to be moved. Everybody's talked about staffing. It wouldn't be right if I didn't do so as well. So across the forensic division, we are also feeling the impact of a number of factors, but that come under the heading of staffing in that sense. So you'll see there about high secure lone working, which is one of the key factors that we highlight to board. That's increased in September to 48 episodes. So that is where there is one member of registered staff running a ward, essentially. In high security, because of the I would say the size, in a sense, we have flexible ways to manage that, and we have oversight and assurance of how that's managed and monitored. Thinking about what colleagues have said already about staffing, for us, it's a combination of ongoing problems recruiting. So there is a national picture to the recruitment, and we have to be a destination of choice, which is very different to sort of, previous eras. We also need to focus for us on our retention, because we are losing staff, sometimes for positive reasons in terms of a career advancement, but sometimes not. We also have issues around bank and agency usage in terms of just how much people can do because of the continued ask over COVID, which is impacting as well on that. But the thing I would say is we haven't got into business continuity situation. So when you look at how bad things could get, we haven't had to, as Manjit was saying earlier, get to any situations of, stopping services or limiting or things that are included in the business continuity plans, particularly for high secure, which involves confinement ultimately as the ultimate business continuity, which thank goodness we've never got into. The finance bit's there, but I'm not going to focus on that because I'm sure Lorraine will later. I'll take questions.
Okay, thanks very much, Sue. Stephen.
Thanks, Chair. Stephen Jackson, Non-Executive Director. It seems odd to be using a microphone to speak to someone who's sitting next to me. It's around the occupancy, Sue, that we seem to have a mismatch of under occupancy, demand, waiting times. Is this because do we have the wrongly configured estate that we don't have enough beds in the right places and too many in others, or is this something more fundamental within our systems where we're not getting people to the right places quickly enough?
It's going to sound like a bit of a circular answer probably, but because of the sort of new commissioning world, for each of my services is probably a different answer. So there isn't a one fundamental answer. In terms of high security, and I suppose what we're doing is we're analysing that to look at what is the clinical need. So for example, in high secure, the referrals into our personality disorder service have drastically reduced, and there is a sense that that's on the back of a lot of investment that's historically been put into prison healthcare to have to reduce. Some people perhaps historically would have come out. So then we're looking at that, but the referrals have changed quite a lot as well. So when we think we've got one pattern for high secure, it's then gone in a slightly different direction. So we're analysing it. In terms of the low and medium secure, that is more around services around us that have perhaps been closed or are closed to admissions, and probably patient populations that we're not necessarily used to providing services for. So that's the work that we're doing to say, okay, if we've got that number of empty beds, is there a cohort of patients that needs a different service that we can provide? And that will be through the provider collaborative routes.
Thanks, Sue. And just before I hand back to Lorraine, just to say that a number of the visits I've done more recently have been in offender health. And one of the conversations you and I had was just recognising the difference between each of our offender health services, as well as the differences between offender health and some of our other services, and some of the challenge that comes from that. Lorraine, back to you for the final piece.
Okay, so the finances then. So for the first half of the year to the end of September, we have delivered the £1 million surplus that we set out to you. We'll recall we, at that point, only have a plan for the first half of the year because the national NHS financing went that far. National announcements have been made about the second half of the year, and we're well underway with planning for that now, along with our peers. In delivering that £1 million surplus for the first part of the year, we have slightly over-delivered our financial improvement programme, our savings plan, but we have done that in a non-recurrent way. Just to draw attention to the capital plan, we are slightly behind the capital plan at this point in time, as are many of our peers in the system and beyond. For us, that specifically relates to us reconfiguring the Sherwood Oaks timetable, and we are increasingly starting to see throughout the programmes, I'm sure many of you will be aware, is some supply issues with some of our schemes. So we keep a very close eye on that, and we'll keep Finance Committee updated in due course. We do have plans that we can to make sure that we commit that capital plan to its fullest over the course of this financial year. That's all I wanted to bring the board's attention to.
Great, thanks very much. Stephen.
Thanks, Chair. Stephen Jackson, Non-Executive Director. Lorraine, I've got a couple of questions. I think if I get them all out at the beginning, and then perhaps you can answer them in sequence. First of all, just a comment that it's good to see that the surplus is being held at the half year. So, not only a good performance by the trust overall, but in your particular area, a really good effort at forecasting. So well done on that. Specifically on the questions, the income on Brampton Hospital that was included in forecasts and now isn't, does that mean that we will not be getting that additional income, or is it just a timing issue? Secondly, then around the FIPs, that although in total again, it looks like a decent performance in that you're ahead of where you wanted to be. When you look at those figures in a little bit more detail, you see that the vast majority of what's been achieved is non-recurrent, and so the level of recurrent savings is below what was anticipated, and I wondered what the longer term impact of not achieving those recurrent savings is likely to be. Thank you.
Okay, thank you, Stephen. So I'll take both of those. In terms of the Brampton Hospital income, not included in the first half of our year position, as you rightly say, despite being planned for that. But we do continue to have conversations with Specialised about that. I can't necessarily easy conversations, but we are in dialogue with them about appropriate funding for all of our specialised commission services, not just those provided at Rampton. And we'll, as we develop the second half plan, we'll update Finance Committee with that detail. For the financial improvement programme, you're absolutely right. I think the non-recurrent challenges, so I know the non-recurrent challenges are not ours and ours alone. Our peers in the system and beyond have found the same challenges. And it's certainly something we discuss regularly at execs about the challenges, given the operational context we're working on, the ability to deliver the financial improvement programme. So the first bit of your question about the ongoing impact, we keep a close eye on our underlying financial position. If what we don't save now, we will have to save at some point in the future to ensure good financial governance. But we have got some specific actions underway, focused in the first instance about what can we do to ensure we get through this financial year and this winter safely and appropriately, and more longer term, working alongside the strategy, what are the improvement programmes and themes of work that we need to do, both internal to the organisation but externally with our partners as well, as we work more closely together. And Becky mentioned the community transformation programme, for instance, and how do we make sure that we work with all of our system partners. So I can give you assurance that we're absolutely sighted to it, but recognise it's extremely challenging in the circumstances.
Great. Thank you. Thanks. Steve?
Microphone doesn't reach that far, I'll have to sit forward. So just to, sorry, Steve Banks, Non-Exec Director, introduce a bit of anarchy to Stephen's control and order. Given the conversation that we've had earlier about where we are on staffing levels, we must have concerns about morale of staff, and it's still November, all obvious things to say. So there must be a judgment call at some point with regard to FIPs in terms of how far do we want to go. And this is a conversation we've had before as a board in previous years, but obviously this is so much more acute now, isn't it? So it's just a request to the board, perhaps particularly the execs, to consider when to say stop. And for me, that moment will be when we know that we're going to drive staff morale, patient care, anything else in the wrong direction. And can we as a unitary board have that conversation, if helpful, to provide cover for all of you. So I just wanted to have that as we should have that as a proper conversation at some point, I believe.
Thanks for that, Steve. I think I'll if I respond to that one, I think that's a really good call for us as a unitary board, and I'm sure executive colleagues will have heard that in absolutely the spirit that it's given, Steve. So, okay, Lorraine, thanks for steering us through that. Just to reflect that we've taken 50 minutes on the IPR this month, and I've got no apology for doing so. I think it's been a month where it's been really important that we've enabled some of those conversations about digging in, and there's a lot that we've had to draw attention to. And again, it's a lot that is of concern for all of us around this table, notwithstanding, as exec colleagues have done, pointing out some of the incredibly positive pieces that are in there. It's a really important piece of what we need to do as a unitary board. So no apology for taking our time on that. We do still, though, have quite a lot to get through. So if we can move on to item 15, the winter operational plan. Becky, over to you, please.
Thank you, Paul. So Becky Sutton, Director for Community Health Services. So this, I'm not going to go through the detail. This is here for assurance. The winter plan is a system piece of planning that we do, and this paper goes through sort of our element of it. It feels a little bit out of date. I think we wrote this in August, and although there's a lot of plans in there that will still go forward, I think there's a few risks in terms of delivery, as we've all talked about and rehearsed this morning. So this really just shows you a level of detail in terms of some of the things we consider from winter. As we've already said, you know, we don't look at winter as a dedicated period, and we could almost argue we're in winter already. But really what this is about is that planning, that revise of our plan. So what happened last year? What lessons have we learned during increased times of pressure, whether that be from COVID or demand? And actually underneath the winter plan is a whole lot of operational triggers that we've already talked about that links us into at what point do we tip into business continuity. So really, apart from saying this is our section as part of the ICS winter plan, this was approved at A&E Delivery Board on the 5th of October, and the paper gives you a level of detail of some of the areas or projects or increased services that we're looking at providing for this winter. probably all to say, Paul.
Great.
Unless anyone's got any questions.
Thanks very much. And we have had sight of the more detailed plan behind this. And as you say, Becky, it is still a moving feast as well. So I'm not seeing any indications for comments or questions on that. And I'm sure you'll keep us alert to any changes as they do come through. Okay, so if we can move to item 16, the application of the trust seal. I did double check that we haven't got a marine mammal therapy service. We don't. Shirley, over to you.
We do. Shirley Higginbotham, Director of Corporate Affairs. This is just a governance process thing, really. Board have previously, through the scheme of delegation, delegated authority to the executive team to apply the seal. The seal's been applied 17 times since April. So this report will come on a 6-monthly basis, just to inform board that where the seal has been applied and to round off the scheme of delegation, so sort of delegated approval.
Great, thank you. And you need a formal approval for this, Shirley.
Yes, please, yeah.
So colleagues, if I could ask for, I'm not seeing anybody waving at me to say they've got any challenges on these. So if I could just get an indication by hand, please, of approval or otherwise of the use of the seal. Thank you very much. So if we come back to Becky for the Emergency Preparedness Resilience Biannual Report, please.
Thank you, Paul. I've got a lot on this agenda today. Again, here for assurance is a 6-monthly update around the Emergency Preparedness, Resilience and Response team and their programme of work. What you will see is, again, I think this team have been really highlighted through the COVID response around how important our statutory requirement around emergency planning, resilience and response is. And the team has been supported by the organisation, and it's gone from 1 person to 3 people. But what I would say is it's amazing what then 3 people can do and the progress that they can make in 6 months with the right team behind them. So again, I'll take the report as read. A couple of bits I want to pull out. So the first thing to say is we undertake an annual self-assessment against the improvement core standards. I am pleased to announce that we're fully compliant with those standards this year. A couple of areas that we perhaps need to look at in a bit more detail, but nothing of concern with those plans at all. The other thing in terms of progress that this team's been making is really around the building of the training and education and the exercising. And there's been quite a lot of work underway around a really comprehensive training programme going forward. That involves staff at all levels, and we've got some really good training and education happening. The other part, some real innovative things that they've done. So developed a QR code, which is a barcode, which is going to go on the back of people's badges, which gives you an instant link to the planning page, which then will be able to have some real key points that if you're in a response mode or something's happened, it will give responders those first 3 or 4 key points. And it sounds really simple, but actually when you're in the middle of responding, or you've got an action card, all you really need to know is those 3 is they change all the time. So actually to have that live link, I think is really quite impressive in terms of what they've done around that. Obviously the other part the team have been undertaking is continued twice weekly delivery of our incident control team, and they've been responding to all the various inquiries that we still get around the COVID response. The report then goes into really what the priorities are for the next 6 months, which is listed within the report. And the only other one that's probably missing from this report is they will be a key part of responding to the national COVID inquiry as that comes on board. And we are already thinking about how we respond to that as an organisation. So having a single point of contact, and we can be very clear around the information that will be required of us going forward. So in anticipation of that, we already have a note out that nobody is to destroy any notes. All of the action logs, the derogations and things that we've kept put us in a really good place in terms of the inquiries that may come through, that response at a later date. That's probably all I wanted to say, Paul, but happy to take questions.
Thanks very much, Becky. I think it just underlies a bit of confidence in the question that Trevor brought through earlier about what were you doing proactively, that looking forward piece, and I think gives us some confidence around that. Okay, I'm not seeing any hands on this one, so thanks for that, Becky. So if we could move then to item 18, the Mental Health Legislation Act Annual Report. Sue, over to you.
Hi, yes, Sue Alcott, Medical Director, Forensic Director. So unlike Anne-Maria's very shiny brochure that she's shared with her picture on, I've got a report in the reading room. So this is the Mental Health Act Annual Report. It's been through a series of meetings prior to this, including scrutiny at the Quality of Mental Health Legislation Committee in terms of assurance processes prior to it coming to board, which it is required to do so. In terms of important things just to pull out briefly, taking it as read, because there's an awful lot of detail in there, which is really helpful. I think the important things are in terms of how the Trust is prepared in terms of the Use of Force Act. There's a lot of work being done about that. It talks about the work that was done to make sure we're compliant with regard to Devonshire Partnership Court ruling. Then goes through figures in terms of detention, CTOs, tribunals, Mental Capacity Act. Then it details the themes around the CQC Mental Health Act visits that have been seen over the year, so that we can take that away and work through the themes. And as you'd expect, one of the key themes in the CQC visits has been around staffing that wards have been highlighting as well. So in terms of things for the board to see, that's the detail.
Great. Thank you very much, Sue. Stephen?
Thank you, Chair. Stephen Jackson, Non-Executive Director. I was just looking in your report at one of the summary points around the very few number of discharges that were provided, either by tribunals or associate hospital managers. I just wondered how that compared to other places. Is it something specifically that we're doing or should be doing, or are we just performing to a standard?
No, that's a fairly normal figure.
Great, thanks, Sue. And you picked up the question I was going to ask Stephen there. Sue?
I had that same query actually, Stephen. Sorry, my name's Sue Nixon. I'm one of the non-execs. And in fact, it was raised because I sat with the associate hospital managers at their 6 monthly forum. 2 points I want to raise. One, that was the same question I raised at that particular point. And actually, if you look at the figures in the table and compare how our associate hospital managers are with the tribunal, we're not that far apart from the tribunal. So I thought that was quite a fascinating point. The other point I would like to raise in relation to that forum that those associate managers have is I'd like to say a special thank you here to one of our higher trainees, Dr. James White, who actually did a really, really good training program for those assistant hospital managers, talking about the different ranges of mental health disorders, how to treat them, the sorts of things that would happen, and the types of things our doctors should be including in a good report that goes both to the assistant, to the associate hospital managers panel hearings, as well as to tribunals. And I'd like to formally place on record, Sue, to say thank you very much. I think Stephen listened in on that, which was part of a MS Teams meeting, and there was high praise from 16 or 17 of the associate hospital managers. So thank you to him. And thank you to 3 people of the associate managers who've retired, one of whom's a lady who's given us 25 years service. Wow. So I think that's was well recognised at that meeting. Sorry to intervene, but it's
it's important, Sue, and I know that Sue will have made a note to make sure that Dr. White is aware of that. Thank you. Okay, colleagues, if we can take that now and move on to the reports from subcommittees. Usual flag, folks, that we take these as read where we can. Sue, if we could start with the People, Culture, Equality and Inclusion Committee.
Take it as read. Most of the agenda actually has been picked up today at this board meeting. I would just ask colleagues to focus on perhaps the last 2 or 3 lines under the board assurance framework that talks about compassionate leadership, and draw your attention to that. And I think many of those comments have already been raised as part of the discussion here today, and particularly my comment, the comments raised by my colleague Stephen Banks, I think I would happily very much endorse.
Thanks, Sue. Good prompt just to focus us on that last sentence, and I saw nods in the room at that as well. Okay, thank you. Let's go on then to 19.1, Sue. You know I've got a comment on this, but shall I just, if I just refer to that, there's one technical change on this paper, colleagues, which is in section 3 on page 2. An area of discussion got in the committee, I think, got placed into this as a point of fact, and I just need to take it out, which is that actually at this trust we don't have for our governors an open invite to attend committees. It is something that some foundation trusts do, but as a matter of practice, we've not done that. So that line will take that out, just to assure colleagues that we will continue to have conversations with our lead governor and deputy lead governor through the steering group to make sure that we are still giving plenty enough opportunities for governors to get scrutiny of non-executives. Shirley, do you want to comment on that before I invite Sue to actually introduce the piece for what we need to do?
Yeah, just to support that, Paul, and also to say that the governors through the Council of Governors do also receive a report from this committee, so it's not that they're missing anything, it's just that they're not in attendance. Great,
thank you. Sue, do you just want to then introduce the item as is?
Thank you, Paul, and thank you for raising that point. The terms of reference for this newly formed committee are now before you, and obviously just need to receive ratification from the board, and that's it.
Great, thank you. So if I invite you to indicate if you approve these, including that amendment that I described. If I could see a show of hands on that again, please. Appreciate that. Thank you very much. So if we could go, Trevor, to the Finance Committee, please.
Thank you, Chair. So Trevor Orman, Chair of Finance Committee. We held the committee meeting on the 30th of the 9th. We had good attendance. And good reports, nice succinct reports presented. The prime areas were already covered today, basically on the financial position, our capital reprioritisation that we had to approve, and some comments that's already been made around the challenge of the FIP, making sure that we get our financial improvement plans in place for current and non-recurrent actions, which we know is going to be a challenge. The 2 other areas I'd pick up, one is the continued focus on the BAF, which I think is helping us make sure that we do ensure we have the right level of governance and actions in place. And two specific areas that we've got to make sure we're focused on going forward. One is the impact of the integrated care system and how that has a financial impact on us. And then the use of the same jargon of impact, making sure that as lead provider collaborative, we are on top of all of the governance and issues that can relate to that particular leadership activity that we've got. So on the 8th of November, we have an extraordinary finance committee meeting to make sure that we are performing the role that we need to as lead provider. So that will be the key focus, and the integrated care system and the lead provider activity needs to be a higher profile for us going forward, and we'll make sure that that does happen through the governance of the financial committee.
Great.
That's it from me, Chair.
Thanks very much, Trevor. And again, if we could move on then to the Quality and Mental Health Legislation Committee. Carolyn, over to you, please.
Thanks, Chair. So again, assuming that people have read the report, the only thing that I wanted to really highlight were the quality impact assessment process, which was presented and approved by this group. This is an important aspect of quality control around our financial improvement plans, and also some additional scrutiny around our Care Quality Commission action plans, because some of those action plans go back 2 or 3 years now, and because we haven't had that review by the CQC, we want to just go back and make sure that those changes had been made sustainably, and received a very detailed report from Anne-Maria's team at the meeting. Thank you.
Great, thank you. That's a really good point of assurance to tease out for us, Carolyn, around just looking back at CQC, Care Quality Commission inspection reports. If we move on to the Strategy Committee highlight report, Steve, please.
Okay, thank you. Again, Teg has read, I think you'll note from the main report detail that these are all areas that we're discussing as a board in other forums as well, but I hope you feel assured that they are, we are having the right agendas at the Strategy Committee, so there's nothing particularly to highlight, Paul.
Great, thank you. And Audit Committee highlight report, please, Stephen.
Stephen Jackson, Non-Executive Director, and for this section, Chair of Audit Committee. There was nothing to escalate to the board that came up in this group, although there were several occasions when issues were referred to other board subcommittees, and I think that is helping the way in which the individual committees work together. Again, taking the report as read, I think the only thing that I would highlight as being slightly unusual was the Information Commissioner's Office audit, out of which we did, pretty well actually. Although there were quite a number of points that were found, none of them were either serious or needing urgent attention. So, although another audit, yes. But it was an audit where we were able to compare ourselves against others, and it was good to see that we came out pretty well against other places.
Great, thanks, Stephen. And again, a useful one just to highlight that was a little unusual, but also good outcomes for us. And then the Council of Governors highlight report. Just 2 things that I wanted to tease out from that was just to flag that our non-executive director recruitment campaign is currently live, and we are in the process of seeking to recruit 4 non-executive directors. 2 of those are to replace colleagues who left during their terms of office, and 2 of them are in advance of a couple of non-executive directors coming towards the end of their 2nd term. And just to say to not only colleagues in the room, but anybody watching, to really encourage applications for non-executive director posts. And similarly, we have got a number of governor elections as well, and similarly to encourage people to come forward and to consider standing as governors. And in relation to both non-executive directors and governors, if any prospective candidates have got questions that would help them in deciding whether or not to apply, please do contact the offices, and contact can be made with key people in order to answer any questions you might have if you want to put yourself forward. So last few points here. I've not had any other notified urgent business. So if we could just move to reviewing our meeting, and just to give colleagues an opportunity to reflect on two things. One is how we've done in terms of our values of trust, honesty, respect, compassion and teamwork, and also just to reflect on the fact that this has been the first time in best part of 20 months that we've met in person. Indeed, as we checked earlier, for actually a significant proportion of this board, it's the first time ever we've met face to face. So I would just like to hear 2 or 3 comments, if I can, from colleagues about how it's gone today. I will pause and wait for hands to go up. Sue.
Hi, Sue Alcott, Medical Director, Forensic Director. So it's my first face-to-face. And having worked in a couple of trusts before at this similar job, it makes a real difference seeing NEDs. I think from a personal reflection, it's very hard to get to know people in a screen, you know, and so whilst we've seen each other as execs more face-to-face, I think actually seeing people is very different. And some people are much taller and some people are much shorter than I expected. So.
Thanks for that, Sue. We won't invite people to stand up, but I did see a number of nods around the table in terms of your reflections as well. Becky.
Thanks, Paul. So again, like Sue, my first time ever in a room like this. So one, it feels a bit more formal, and that's probably just me because I've not sat around a table like this. But my other reflection was, I think from the patient story at the beginning, it felt it came over a lot better than in person than perhaps it does on the screen. Okay. And I know we've had some great patient stories, but certainly, you know, there was a bit of a better interaction, and I think it really landed perhaps a lot better than it does via a screen. So I certainly found that really, you know, quite thought-provoking, but also, you know, you got a real response from the patient around his services.
Thanks, Becky. Yes, I'm sure Colin's, particularly Colin's input for that was really, really helpful for us. Anybody else want to have a go? Trevor, and then John, and then I'll wrap.
Just a quick comment. I agree with a lot of the comments that were already made. Just seeing people for probably over a year or more is quite unusual now, but really enjoyable. I think one of the things that comes across me, we are in an environment where it is pretty tough, and I think celebrating some of the success stories and some of the good things that are going on is really, really important, because it's very easy to fall into the negative and why isn't it working and why has it gone red or why is the trend down. But there are an enormous amount of good things that are going on, and we must keep that to the forefront so that you leave with a positive feel. Great, thanks very much, Trevor. And John.
Thank you. To follow that and link the two is the patient story was a sort of microcosm of our task, wasn't it, in terms of many challenges that Colin overcame, and despite that hung on in there and got to a good place. And I think that's our job to do for the organisation. I've been reprimanded by a member of staff not to refer to us as the organisation. It's the trust. Whatever happened to Notts Healthcare, call it a trust, don't call it the organisation. So I'm going to correct myself all the time because it was a good challenge. So the trust. So the patient story was good. It's great to see everybody in real life. I think it's, as Becky said, it's much better for everybody, isn't it? Better for us. And particularly to thank Grace, Lauren and Kira for the infrastructural support to get us all plugged in and wired up and safe and fed. I know it's taken some time to do that, but yeah, no, it was good. Good meeting. Thank you.
Great. Thanks, John. And certainly echo that. Thanks to Kira, Lauren and Grace as well. It's been really impressive what you've been able to put in place behind the scenes for us. And I think you've enabled us to have a good meeting that has meant we've been able to give proper consideration to everything without worrying about our environment. I'd also add the technical support we had from Luke and Jordan as well, including some last minute bits that I flung their way first thing this morning. So we do need to, as always, formally resolve that we move towards a confidential part 2, but we will take a break which will enable us to get a little bit of sustenance and also just to rearrange the furniture a little, because I think for our part too, we'll be able to, still maintaining the social distance under Anne-Maria's careful watch, we will be able to, I think, come round into more of a rectangle. So the last thing I'd like to say is thank you to our observers. Really appreciate people coming and spending time observing us in person, as well as anybody who may observe online as well. So thanks very much, everybody. We'll call a close to our part one business. Thank you.